Kenya, live from the Strathmore Business School. Follow the conversation on our social media platforms and help build a stronger, healthier and vibrant nation. Transform Kenya. Empower our nation. Transform Kenya, brought to you by Standard Group in partnership with the National Hospital Insurance Fund NHIF, Ministry of Health, Cosmos, Jubilee Insurance, Amref Health Africa, the Nairobi Women's Hospital and Strathmore Business School.
Welcome back to Transform Kenya, the forum to empower our nation. And the discussion this evening is on the health agenda and on access to health. Just before the break, we were discussing pharmaceuticals and access to medicines. And as we discuss this issue of pharmaceuticals, we have universal health coverage at the backdrop of it. It is one of the issues that really will determine if we will achieve that dream of everyone not being left behind when it comes to healthcare. And I would like to introduce Dr. Rudy Eggers, who is the World Health Organization country representative, to just tell us what UHC is, and most importantly, what is it not? Because we have seen discussions in this country where we think that with an insurance cover of any sort, then I have universal healthcare. Is this the case?
Thank you, Mercy. It's a very interesting discussion. I think the first thing that I'm very happy about is you showed the tweet by Dr. Tedros, the World Health Organization DG. It is a political choice. And I think this is what's great in Kenya, that in fact that political choice has been made and it has really energized the health sector. What is UHC? Many people have got different ideas about it. For the World Health Organization, it has three components. The first component is access to services, or also equality in services. So if you are in Turkana, if you are in Nairobi, if you are in Makueni, you should be able to access similar services. The second component is quality of services, to make sure what you are being delivered is really of high quality. And the third component is financial protection, so that when you access services for your health and well-being, that it does not cause you financial hardship. I often hear people talk about universal health care, and we should avoid that. It's not universal health care, it's universal health coverage. Why? If you talk about universal health care, it sounds as if you will get all services, any and all services. That's not the case. What is meant by the universal is everybody. So everybody in Kenya will be covered by this service. So let's talk about universal health coverage rather than universal health care. Now, you mentioned what is UHC not, and that's sometimes quite important. So often we hear programs, immunization program, HIV programs say we are UHC. No, of course, the treatment of HIV and immunization and all the programs are part of UHC, but as such, it is not UHC. Or a specific population group, the indigent, the pregnant woman, the elderly. Sometimes we hear, this is UHC. No, again, it is everybody. We hear about UHC being described as the health insurance. But no, it's not only about health insurance. It's not only about the financing. It's about the service delivery as well. So health financing is a very important part of it, but it is not only health financing. And finally, it's not a piece in one county or another county, but it is really countrywide. It must be understood as being covering the entire country. Clearly, you will have different UHC in different parts of the country. You have more malaria in one county and less in the other, so you'll have to deal with it differently. But clearly, this is something that has to be seen as a countrywide activity. Thank you.
Okay. Thank you. Thank you very much on that opener on universal healthcare coverage. And you've mentioned quite importantly that we are seeing counties, each county is coming up with its own version of what they call UHC. And I'd like Dr. Aman to now come in here. If each of the 47 counties comes up with their own, then we'll have 47 different outfits, but how will we be able to know which one is what is envisioned in universal health coverage?
Thank you, Mercy. Indeed, it is true that if every county came up with their own universal health coverage, we could end up in a big mess. But as a national government, the leadership has already been provided, as Rudy has said. His Excellency pronounced attainment of universal health care by 2022 as one of the big agendas. And of course, that has a strong political statement. And with that statement comes a lot of focus and support to the field. We are approaching universal health care from a point of view of being able to provide universal health coverage to the entire population of Kenya. Of course, it's a big task. It also brings to question what kind of health coverage are you going to be able to provide. We as a ministry have, over the last several months, been undertaking various tasks, including benefits package. A panel was gazetted that is working out a suitable benefits, an affordable benefits package, which we are interrogating, and it will be part of the roadmap that will be rolled out. So as a national government, our role is really to provide the policy direction and the guidance. And when we roll out this universal health package that we are developing, and having considered it from all points of views, the approach that we are taking is precisely because of what you said, is running a test, running this package in 4 counties that we call our pilot counties. So we will pilot this package, which should be able to provide 100% coverage to all the Kenyans within those counties. It will be financed by the government. The package should be affordable, and it will provide basic essential services, both outpatient and inpatient. During the period of piloting, we intend to learn lessons from this program, and we will carry forward whatever less positive lessons we learn, and then we shall be able to roll that out on a national scale to all the 47 counties, regardless of whether they have their small county UHC or not. Because, a commitment of this nature, where the government has made a commitment to provide universal health coverage, must succeed and must be sustained. And sustainability is an issue. Sustainability is an issue. You can have many different models, but sustaining that model and looking at the maths of it all to make sure that it is able to be sustained is important. We believe that where we are and the consultations we had, the program we intend to roll, we believe that we can achieve universal health coverage by 2022, the target that has been set.
So one of the pillars that Dr. Rudy has mentioned is the financing aspect of it, or being able to afford healthcare services. And we have pegged a lot on NHIF. And Mr. Mwangi, what role specifically is NHIF playing in this journey towards universal health coverage?
Thank you. NHIF is basically a social health insurance. With that, we have the mandate to pool resources in a manner that people pay their contributions, structured contributions from the formal sector and also from the informal sector. And the whole idea is to have people subscribe to social health insurance so that we have enough resources to be able to cater for the medical conditions as they arise. We are part of that discussion when it comes to universal health coverage, and we should be able to plug in the benefit package and be able to roll it out to the participating providers across board.
1.3 billion set out in this financial year for UHC, and we are looking at providing quality services. We are looking at an increased healthcare workforce if we are able to provide those services. We are looking at the pharmaceuticals and diagnostics in that sector. We are looking at even getting community health workers who will actually be the anchor of primary healthcare. 1.3 billion, is this really adequate looking at the enormous task ahead?
Well, I don't know where you are getting the figure from.
This is the 2018-2019 Kenya Health Budget.
I think that would be a bit different from what we are doing when it comes to providing a respective benefit package and working with the 4 pilot counties to see how does that penetrate and to see how does it fuse up to the what currently NHIF is providing. There is the aspect of availing contributions for those who are not able to or have no ability to pay. There is also the other aspect of pushing the informal sector and see who can put up their contributions. And then there's the aspect of the pilot we are talking about to see that which studies do we learn and how can we roll out this in the entire country. So I think the ministry is still on the drawing board to see exactly what kind of funding do we get and become sustainable. And I think we are still at the tail end of that discussion at the moment. So part of the resources that the ministry have from their budgetary cycles is what we'll see and see how it is plugged into that pilot.
Okay. Dr. Kitulu, you are itching on this one.
Yes, I am definitely itching to discuss that subject because the way we would like to look at UHC as a journey, not a destination. And as soon as we peg it to 2022, it's become a destination. And we lose focus of what the journey is. I want to look at UHC as having a width, a breadth, and a depth. And look at UHC as if you are in a family. I am a mother, so I'll look at it from that context. And I have my family that I need to feed. Now, I can't give them everything they'll want all the time. Number one, because they're limited resources. So I cannot give them all the, whatever they might want, they might desire. But I can plan about how much I can give them to ensure that everybody gets a nutritious meal that feeds everybody and keeps them healthy. So I want to look at UHC in that direction as a country, that we have to look at it. I think part of what distorts our discussion of UHC is that we have almost gone into the narrative of healthcare financing, what Rudy Eggers was saying, that healthcare financing is not UHC. So we almost look at insurance as UHC, and yet it's only one component of it. So in that concept, therefore, then we need to look at it more broadly. What is it that requires on that? First of all, if you're going to say universal coverage, then it's the breadth, everyone. So what can we give that covers everybody with the resources that we have? Now, those resources, how are we going to get those resources? Yes, there's the budget. We've talked about the budget declaration that, yes, the national budget, probably 15% should be put towards health. We're talking about then how do you collect those more resources to fit that area? And we are looking at probably a more progressive system, a tax-based financing probably, where those who have more pay more, those who have less pay less, and someone pays for those who do not have, but to ensure that there's a basic package. And I like the discussion from Makueni that it's if you focus on primary healthcare, focus on promotive, preventive, you're keeping everybody healthy, then you have less requirement to move to the next stage. If you look at what we are focusing on right now, and even lots of those packages and even what NHIF tends to focus on, it's a very disease-based financing. It's a curative model. The idea is avoid getting them into that curative, the point of curative, because as long as we don't look at it that way, then we are not getting that universal health coverage. Really, we should be focusing on a journey that ensures that there's a primary cover that everybody can access, that there is promotive preventive care focused on. The way we collect those resources, then that there'll be then the few who progress to the next levels requiring secondary, tertiary care, there's funds for them, that there is funds for health workforce. Because if you're going to increase coverage to everybody, it means you need more workers so that you'll be able to finance those, that you'll be able then to finance research, you'll be able to finance training, actually do a lot more than actually just treating diseases. So as long as we don't move away from that disease focus and also just the financing aspect, we keep on getting caught in this quagmire of not moving from the spot. Let's think broadly. What will cover everybody? And then we progress. Then we'll increase the depth. Once you've reached that point where everybody has a nutritious meal, then you can move on to the next depth and say, we can add in some luxuries. Sometimes we'll have dessert, and sometimes, you can move to the next level. But you can't put everything in that pot. Basically, you would say you cannot provide everything to everybody all the time. We have to define what we can.
From your discussion, if you're going to focus on the basics, that it means there should be an interplay with also other sectors, housing, for example, food security. Then we cannot have this discussion on a singular lens. And I want us to continue with this discussion. Just hold your thoughts, because I'd like us to release our viewers who are watching us on KTN News. But we continue with this discussion here at the Strathmore Business School and on live stream. We release our views, but this conversation continues.
Let's continue the conversation on all our social media platforms and help build a stronger, healthier, and vibrant nation. Transform Kenya. Empower our nation. Transform Kenya, brought to you by Standard Group in partnership with the National Hospital Insurance Fund NHIF, Ministry of Health, Cosmos, Jubilee Insurance, Amref Health Africa, the Nairobi Women's Hospital, and Strathmore Business School.
And we continue with this discussion. And Dr. Aman, you're really nodding and you want to contribute on this one.
To respond to my colleagues'
KTN News. Get the whole story.